Happy Valentine's Day to everyone. I almost forgot to wear any sort of red or pink, but I have one pen right here. The consequences of a 1-year-old being awake all night. Yes, ma'am.
Can I read Dr. Austin's part?
Yeah, sure. Go ahead.
Dear class of 2020, have a very special Valentine's Day. Remember, you can celebrate Valentine's Day any day, all year long. The key is bringing joy to your heart.
Aww. Very sweet. I heard those chocolates were laced with Paxil as well, so everyone's mood should be lifted. Having some of that chocolate. Oh, weird. Interesting. David was asking, is Valentine's Day a particularly rough day at the Poison Center? And I said, yeah, it's not so bad. Thanksgiving and Christmas for sure, but not so much Valentine's Day. But let us continue on. Let's finish up our talk on rheumatology, and then we'll start getting into the OB-GYN section. So we have 2 more class periods for lecture time. Then we'll have the review, and then the test, I believe, is on the 25th of this month. So just be aware of that. I haven't written the test yet, but that's coming out soon, so I should probably get on that, right? Anyway, let's keep going. We were talking about osteoporosis, osteopenia. Also, that reminds me, I should probably tell you to, good luck studying tonight, because I'm sure you're not going to go out for any romantic dinners, but studying for your OSCEs. I would tell you to break a leg, but you guys probably all have nice strong bones, so that's not going to happen, right? It's like good luck thing to say. Break a leg. Anyway, all right. So let's get into our anti-resorptive therapy. The kind of the gold standard in this group is going to be the bisphosphonates. This includes a couple different drugs. Alendronate, ibandronate, and rosendronate are the main oral options you're going to find here. Zoledronic acid is going to be the IV options given here. The big differences between these are usually going to be how frequently they have to be administered. A lot of them can actually be given very infrequently, either like once a week, sometimes longer than that. Actually, zoledronic acid, anyone know how often you have to give that? Actually, 1 time a year. So actually only go in for an IV infusion, and they're basically good for the entire year, which is kind of interesting from that standpoint. Basically, the mechanism, how it's working, they're trying to mimic this product called pyrophosphate, which is normally found in the bones, and it's a natural inhibitor of the osteoclast. So it kind of prevents them from getting more mature, kind of decreases the number. They can't really adhere to the bone quite so well, and then will also decrease that lifespan of those osteoclasts. So again, we're trying to rebalance that more towards the osteoblast laying down the bone rather than the osteoclast taking up the bone. And so by trying to mimic that pyrophosphate, it's going to try to bring that balance back towards the osteoblast activity being a little bit higher there, right? So the kinetics here are super important, and this is good patient education information with these drugs, is that the bioavailability is terrible for these drugs, right? Less than 1%. Which one do you think has the best bioavailability? I mentioned on the last slide. Probably the IV one, right? Because again, that's 100%. You can administer it right to the veins. So that's kind of goes to show you like why that one only has to be given 1 time a year. All of them have very long half-lives. I don't have to give them that frequently, but the bioavailability is what is really going to limit this. So the administration tips on this are going to be really important, how you tell them to actually take the drugs, as we'll see in just a few minutes here. But once they're incorporated into the bone, they have a very, very long half-life. Stuff that gets incorporated in the bone typically sticks around for a very long time. Then we know what other metal likes to accumulate in the bone. Maybe if you're living like in Flint, Michigan. Lead actually does too, right? So if you actually had kids, and if you think about who has like kind of the most rapidly developing bones amongst people, kids, right? Because again, they're building up their bones, and so because they're rapidly taking up a lot of calcium, if they're in a calcium deficient state, the body's going to take up stuff that looks like calcium as well. And lead actually looks a lot like calcium to the body, similar to how lithium looks like sodium. And so you can actually find kids who have significant lead exposure, but you can find on X-ray, you can actually see lead lines. You can actually see where the lead exposure occurs there, and that will be more radiopaque than the actual bone will itself. So if you can Google images of that, but it sticks around for a very, very long time. Anything that gets incorporated to the bone there. And that's why they have a biological half-life up to 10 years, because once it's there in the bone, it likes to stick around for a good long time. So as I mentioned, the oral agents have to be taken correctly in order for any of it to be absorbed, and I'll talk about some tips on that in just a few minutes. And the biggest ADRs you're going to run into this is most commonly probably going to be the GI upset here. A lot of these pills can have a tendency to get caught in the esophagus, especially if they're not administered correctly. That can sometimes lead to erosions or ulcers potentially. It's more rare, but certainly you can see some GI upset, some heartburn, dyspepsia related to this. And then actually one of the more severe sort of side effects you can see with this is osteonecrosis of the jaw. And in fact, I had a family member who was taking Fosamax, and actually had to stop taking because they went to the dentist and actually found they're having some bone erosion that was actually occurring there that was related to that. So I actually had to DC that and had to switch over to something else. Some other options we'll talk about a little bit later. So just be aware of that. Any kind of like jaw pain, or if they're going and getting dental checkups and notice anything like that, you should definitely go ahead and discontinue the medication altogether. But you have to make sure that they are taking this medication with just water, nothing else. No coffee, no grapefruit juice, no milk, no nothing else. It's going to decrease the bioavailability even further to almost zero, right? So I need to take it with 6 ounces, 8 ounces of water, no other liquids. They need to remain upright for at least 30 minutes after they ingest the pill, with no other foods or other liquids going down, okay? It's going to allow it to get in the stomach, nothing else is there. So again, take it right upon waking in the morning is usually the best time when the stomach's nice and empty, and that will allow for the drug to be absorbed. Again, if they lay back down afterwards, what could happen? If it gets stuck in the esophagus, it could have one of those erosions and ulcers potentially could occur there. So that's why we tell them to make sure they stay upright, make sure it travels down to the stomach where then it can be starting to dissolve and get absorbed.
Is it like a large pill?
It's not necessarily large, it's just something with the pill itself. The characteristics just tend to get stuck for whatever reason, right? And if you think about a lot of like older patients, they may be more likely to be more recumbent, and that's why we have to say, hey, if you can't sit up for at least 30 minutes, it's not going to be a good product for you. It's just one of those things that's just associated with these drugs. I'm not sure if there's a particular mechanism why. Good question. Maybe there's some research out there I'm not aware of. And again, as I mentioned, the dosing strategies can be pretty different between the different agents here. Some are weekly, some are monthly. And as mentioned, yearly is a big thing with that, with the zoledronic acid, which is nice. Typically, you'll find patients will start out on the oral products first to see kind of how they tolerate it, and then if that's something they want to switch over to with the zoledronic acid, that can be a good thing. You usually don't want to start off with that one if you don't need to. But again, what do you think that does for compliance? It's easier to remember to take something every single day, or like once a month, once a week. Probably depends on your patient, right? They can set good calendars for themselves or good reminders. I basically live my life through my calendar. If I did not have that, I would have no idea where to be. I probably wouldn't be here right now. I'd probably be still sleeping or something. But that's important. So make sure they have a good calendar set up so where they can remember to take it. Again, just a few days later early is probably not going to be a big deal, but just make sure they know. Some people do better when they're just taking the pill every single day. So that way they get into the same routine. Just depends on your patients, right? So another product we have here called denosumab. So you see the name there, you already know it's a monoclonal antibody. Prolia is the brand name. This one is actually a monoclonal antibody that binds a protein called RANKL, R-A-N-K-L. And basically what this does is it will prevent this RANKL protein from binding to the rank receptor. And this is actually a receptor that's present on the osteoclast precursor cells, so before they actually mature into actual osteoclast. And normally this RANKL protein is typically a stimulator of the osteoclast development and maturation. So by binding that, preventing that from interacting with those receptors, they stay in their kind of their more immature sort of form, and they can't really work to take up the bone there, right? And again, it's a monoclonal antibody, so it's going to be a parenteral product, so it's given sub-Q, and usually every, you see this kind of peak concentration within 10 days or so. So that's a pretty slow onset here, and usually it's going to be dosed every 6 months. So again, that could be a nice thing from a compliance standpoint. They just come in for an appointment every 6 months or so. That can be decent from that standpoint. Biggest things to worry about is just going to be skin infections at the site, some local injection reactions. And actually what you can see is because normally our bone always static? Is it never changing in most healthy adult patients? No, it's constantly turning over, right? We're constantly laying down new bone, taking up old bone. And so when you have this drug on board, you can kind of suppress that turnover, right? And so again, what the long-term consequences are, we may not really know. But that is something that they have noted with this drug here. Okay. Again, this wouldn't be a first-line agent. This would be kind of a backup to the bisphosphonates. Up next, we're going to have our mixed estrogen antagonist agonist. We're actually going to talk about these in the OB-GYN section coming up, so we're going to review that in just a little bit. So don't worry too much about that right now. Just know that we can have certain drugs. When we say selective estrogen receptor modulator, what do you think that means? So it's selectively modulating estrogen receptors, right? So you can say that and sound very smart. But what does that really mean? It means it's going to be acting as an agonist in certain tissues and an antagonist in other tissues. So we're going to look at some of the clinical implications of that in the OB-GYN section coming up. Okay. Anyway, next we have calcitonin. Is this a product we naturally produce ourselves? It actually is, yeah. So we're actually using recombinant products. They don't know what animal we actually get this from, if you had to guess. Hamster, maybe hamsters is a good thought, right? Because we get heparin from hamster, Chinese hamster ovary cells. Salmon, salmon is where we get that from. Oh, did I put it on there? See? We actually get it from salmon sperm, of all places. Now, again, who the scientist was that actually sat there and figured that out, we don't know. We don't know the story, okay? But we do know that's where we get our form of calcitonin from, okay? So again, basically, this is an endogenous product. It's actually something that gets made from the thyroid. And basically, this is the flip side of PTH, right? We said PTH is normally trying to stimulate osteoclast activity. Calcitonin is going to be the thing that kind of helps to inhibit that. Okay, and also you can use this in cases of hypercalcemia. Calcitonin can be used for things like Paget's disease and things like that. So you'll see this in other cases than just osteoporosis, osteopenia. Usually, if this is being used, is because they cannot receive other products, right? So, for instance, they could not receive a bisphosphonate, then maybe they could use calcitonin as a kind of a backup agent. What you end up finding is that with the clinical studies they've done, the bisphosphonates are very good for helping to prevent things like vertebral fractures, hip fractures, femur fractures. This one doesn't have as good evidence behind it. We'll see that there's some evidence for helping to prevent vertebral fractures, but we don't necessarily know if it works all that well for hip and femur fractures. There's nothing to say that it wouldn't work, but we just don't have the evidence to actually show that. So that's one of the issues we're going to see with that. But again, more often you're going to see this used for cases of hypercalcemia because it's going to suppress that PTH. It's going to suppress that osteoclast activity. You're going to have less calcium being absorbed from the gut and more calcium being excreted from the kidneys by doing that. Okay. Usually this is going to be an intranasal form you're going to find. So if you ever see patients getting this as a nasal spray, that's how we most often see it. Anyway, next we have teriparatide or Forteo. This one is actually used very, very sparingly for the most part, but basically if they have really high-risk fractures and they cannot take bisphosphonates, maybe they had evidence of osteonecrosis or they can't receive any of these other drugs, what this does is it actually kind of mimics a certain amino acid sequence of parathyroid hormone. Okay, that's kind of similar activity, and so what it does is it actually helps to stimulate bone formation, will help to stimulate the osteoblast number and activity. However, what they find was it kind of overstimulating the bone. What can happen there? You can actually see cancer develop by that. Just like if I overstimulate estrogen receptors in the breast tissue, what could happen? You get breast cancer, right? So the same thing can happen here, and so they're concerned about this cancer risk associated with this, and so they actually recommend it for taking less than 2 years, if you have to take it at all, and you actually have a REMS program to help with the monitoring for that, right? REMS programs are meant to help them mitigate some of those really significant risks that we know happen with certain drugs. They're like Accutane. Anything else you can remember had a REMS program? Actually, all of your long-acting opioids like methadone, Oxycontin, all of those have a REMS program associated with them as well, right? So those are things you have to think about. Anyway, so again, this is pretty much a easy stepwise sort of approach to how you manage these patients. So the first thing, what are you going to give these patients if you're worried about them developing osteoporosis? Calcium, vitamin D. If they got bad kidneys, what are you going to give them? Calcitriol, however you want to pronounce it, tomato. Those are going to be the best options there, right? Remember, calcium, vitamin D you can get over the counter, no problem. Calcitriol is a prescription product, so they would need a script for that. Then after that, what are you going to start off with? Then the bisphosphonates come into play. So that's going to be your gold standard. A majority of patients can be managed on those bisphosphonates. And again, you're deciding how to treat based off of their scans, what their risks are for fractures coming up. I'm not going to get so granular to be like, hey, this patient has a 2% risk for having a hip fracture in the next 10 years. I'm not going to get that granular. But I will say, patients say failed bisphosphonate therapy, what would be a good next step? Okay. I could say like glucosamine chondroitin, and you'd be like, oh no, that's more for osteoarthritis. That wouldn't be right. I could say something like teriparatide. You'd be like, no, I'm not too worried about the bone cancer risk. What would be a good another step? Oh, maybe denosumab, right? Maybe that would be a good actual one to start out to go to next. So you can kind of think of that stepwise approach based off what they're responding to, what they're not responding to, they have toxicities, etc. And remember how we have to administer the oral bisphosphonates? Just 6 or 8 ounces of fluid, just water, no other types of fluid. They need to stay upright for at least 30 minutes. Okay. All right, moving up into gout. What is gout? Okay, it's a consequence of hyperuricemia. What's happening specifically, though? Yeah, you're basically having this precipitation of urate crystals. Where does it like to show up at? The big toe is classic. They call it the great toe. I think it's an okay toe. It's all right. I guess it keeps us upright for the most part. It's not the pinky toe probably is kind of vestigial at this point, right? But the great toes, yeah, you always think about that getting hit. What type of patients do you think about as getting gout? Obese individuals, like a lot of red meat in their diet, things like that. I think like older gentlemen who like to eat steaks a lot, because you have a lot of those purines that get broken down from the red meat that can then turn into uric acid eventually. It used to be what they consider like a rich person's disease back in the day. This is back in olden times, because those are people that could afford meat, right? And they developed this gout. You've ever seen those old pictures, like the old drawings of what they kind of describe gout like? Yeah, what did you say? Yeah, I always see these like little devils with pitchforks. They're like poking the big toe. And you can Google those. They're kind of interesting, but it kind of gives you a good like remembering. Oh yeah, I remember the great toe with gout. That's the thing you think about. Can it affect other parts of the body? Absolutely. Where else can it manifest? Yeah, kidneys are a big thing, right? You see crystals there precipitate out and cause acute kidney injury. Other joints as well can be affected additionally, right? Good. But again, it's all kind of relating back to this hyperuricemia that develops here. And as I mentioned, uric acid can be developed from things like purines that are broken down from things like meat ingestion and whatnot. Where else might you see this become a problem? Hyperuricemia. Well, I guess like where else could you see a lot of uric acid coming from, like this development of it? So one thing you might think about is actually we can have this something called tumor lysis syndrome. You guys ever heard of that? It's something you can have with patients, especially like leukemia. So if you imagine someone has a white count that's extremely high due to leukemia, they're now diagnosed, and you give them cancer therapy, you give them chemotherapy like cyclophosphamide or something like that. What's it going to do to all of those white cells? It's going to destroy them all, basically, right? It's going to kill them because they're trying to rapidly develop, but it's going to, destroy that DNA essentially. So all those purines are going to get leached out, and then they get turned into uric acid. And so that can be really precipitously, can be pretty bad for the patients due to the fact that hyperuricemia is going to kill the kidneys essentially, and it all precipitates out. So that can be a big problem. So we'll talk about some therapies for that as well. That's the other case I really think about hyperuricemia. That's more common. You see like tumor lysis syndrome for kids with like cancer is where I kind of think about that most often. Anyway, yeah, so basically what you're having is these monosodium urate crystals. Basically, they're going to be in a state where they're precipitating out. Think about it in like more acidic environments, you're going to see this, and more when you have patients who are dehydrated, you tend to concentrate that uric acid. That makes it more likely to occur as well there, okay? And again, I mentioned that renal disease being a big other consequence as well. And again, that damage can be sometimes irreversible, and hopefully if you catch it early enough, can manage it, and it can be reversible. So as I mentioned, you're going to have these uric acid. I'm going to show you a picture of what the biosynthesis and breakdown of these products are to develop uric acid, and so we'll memorize that in just a few minutes. We'll see that. I'm just kidding, you're not going to memorize the whole pathway, but I'll show you where it's important to know where the drugs work. Anyway, it's a waste product, right? And that's why we get excreted through the kidneys, because that's how we get rid of a lot of our waste. And so you're going to find that the two big issues here could either be due to overproduction of uric acid, or it could be due to underexcretion. Okay, so with the overproduction, it could be due to the facts that you have an enzyme abnormality. Maybe it's not metabolizing uric acid effectively. You could have an increased breakdown of nucleic acids. As I mentioned, that could be with like meat ingestion. You could see that with other types of food ingestion. Excessive cell turnover, though, that's where you're going to see that tumor lysis syndrome that can develop there with those patients. On the underexcretion side, it could either be due to dehydration, right? Because again, when your body's in a dehydrated state, what does that do to renal blood flow? Usually decreases, right? Because your body's trying to preferentially keep the intravascular volume up. It's not going to want to cause you to urinate. Or it could be idiopathic potentially. So we'll look at ways we can either treat either side of this potentially. Which way do you think we're going to be targeting more frequently? The underexcretion or the overproduction? We're actually going to be targeting the overproduction. We're going to find ways we can try to inhibit this formation of uric acid, and I'll show you how we do that in just a little bit. So our goals. And again, this is a case where you're going to be looking at prevention of gouty flare-ups and actual acute treatment, okay? And again, what's the biggest manifestation when you have a gouty attack? A lot of pain, all right? So again, a lot of the therapies we're going to be shooting for are actually targeting that pain and trying to deal with that. So we're going to see a lot of NSAIDs and other analgesics associated with that. But basically, we like to terminate an acute attack if it's occurring here and try to prevent any kind of recurrent episodes of arthritis that develops there. And then we're going to break that down into both our anti-inflammatories, and then we're going to look at our urate-lowering therapy. This is the classic urate-lowering drug you think of. Talked about it before. Colchicine is a good one. That's actually going to be better for like the actual acute gouty attacks. What's the other thing though? Allopurinol. Yeah, have you ever heard of allopurinol? That's the drug we're going to talk about as being really good for urate-lowering therapy. Non-farm stuff you can do, apply ice to the area. That's going to be a useful adjunct. But the big thing to try to deal with the actual arthritis itself for the acute attacks is mainly going to be NSAIDs for the most part. It's going to be the big thing. Corticosteroids can sometimes be used for more kind of severe flare-ups. We'll talk about colchicine just a little bit. And the ideal thing you want to do is try to treat early on as best you can, right? So the sooner you can get treatment on with symptoms, the better off they're going to be. And typically you can use combination therapy, so maybe NSAIDs plus a corticosteroid, or NSAIDs plus colchicine if they're having very severe pain, or if it's affecting a lot of different joints all at the same time. So as I mentioned, NSAIDs, you can review those pain management slides as far as what the risks associated with that are, adverse effects, etc. So I'm not going to belabor those points here. As far as corticosteroids go, typically you're going to find that they are equally efficacious to the NSAIDs for the most part. Which one do you think has a faster onset, NSAIDs or corticosteroids? Probably the NSAIDs, yeah, because again, corticosteroids take time to work at the nucleus. Or the NSAIDs are working directly on the COX enzymes to try to prevent that prostaglandins from being produced there, right? In some cases, you may be able, especially if you only have a very few number of joints being affected, you can actually do intra-articular corticosteroids, like triamcinolone is one option there. Or you could be potentially using more systemic therapy if several joints are being affected, so say more than two, or very severe pain. This is where corticosteroids systemically used can be a good idea. And again, if it's more than a week, you got to taper off of it to prevent adrenal insufficiency, right? More than a week, adrenal gland shut down. So you got to taper it at that point. So colchicine is a new drug here we're going to talk about. It's actually an anti-mitotic drug. So if you remember back to our talk of cancer, remember we had a couple of different types of drugs that worked on the spindle fibers in the cells. And remember what those drugs we used? We had the vinca alkaloids like vincristine, we had the taxanes like paclitaxel. They either worked on the production or the preventing the breakdown of those microtubules during mitosis. Well, this is actually working on a similar site in the microtubules itself. So they're antimitotic, which means it's preventing cell replication in some rapidly dividing cells. You already know some of the side effects you can expect to see from something like colchicine. But what it's doing in gout essentially is it actually helps to inhibit the neutrophil locomotion and the migration to those sites of inflammation. So less neutrophils actually making to that site, less inflammation is going to be occurring there, and that can help to deal with the pain. Okay. That's really the best thing it's going to be doing. They find that the sooner you get it on board, the more efficacious it tends to be. After 36 hours or so, really not going to find a whole lot of good effects there, because again, by that time, all the neutrophils that have going to be migrating to that site are going to be there anyway, right? Now, actually, what we used to do when we would dose colchicine, because we know that when you're hitting a lot of these rapidly dividing cells, what's a big organ system that gets hit? GI, yeah. So actually what we would do with colchicine, we would give basically continually increasing the dose until the patient threw up, and then you say, okay, that's the max dose you can receive. So you kind of just keep giving it until they threw up, and like, what kind of dosing strategy is that, right? Like, just keep taking this until you get really sick, and then you'll feel better. Like, what? That doesn't make sense. So nowadays we have a little bit better treatment strategies. We have some like extended release products we can use potentially. But definitely the biggest thing you see is nausea, vomiting, diarrhea associated with this, because again, you're hitting those rapidly dividing epithelial cells in the GI tract. Okay. Other things you can find, especially with more long-term use, are going to be neutropenia. So again, infections can be a big problem, and then you can see some neuropathies that can actually develop as well here. And so, in fact, I've never actually seen one, but we always talk about colchicine as probably being one of the most dangerous overdoses you could ever have, because once it's in the system, it's kind of there, and once it can cause really profound neutropenia, especially in the week after the ingestion. And at that point, the infection is probably what's going to kill the patient at that point. So it can be very, very dangerous. But again, most patients are not really going to have, you don't say it's being used quite so often as it used to be, but you'll still see that occasionally there for some gout patients. Anyway, so how we would manage these patients for the acute gouty arthritis, we're kind of looking at the pain. Let's start off with the mild to moderate pain. Again, initiate monotherapy, especially if a few number of joints being affected, or moderate pain. NSAIDs are good. Colchicine could be used. You could try a systemic corticosteroid potentially. Most often, though, I'm probably going to see an NSAID being used first off, right? So if you had someone showing up to the ER and they say, oh my gosh, my great toe hurts so bad, I need something for this gouty attack, what's a good NSAID you can give them? Toradol, actually, Toradol is a really good one, right? Because that's parenteral. Yeah, you could use indomethacin potentially. Usually you don't find indomethacin used IV. We used to have an IV product that was actually used to close PDAs in NICU kiddos. But Toradol is definitely the one we probably go with most frequently. There's an IV form of ibuprofen that most pharmacies try to like not let you guys know about, because then you'll start to ask to use it, and we're like, oral ibuprofen works just as good. It's more expensive. Just like IV Tylenol, once you guys found out about IV Tylenol, it was all downhill. Like, why can't we use IV Tylenol? It's like, because it's $35 a bottle. And they're like, well, that's not that much. And I was like, it's like 2 cents for a tablet. Didn't work. It's everywhere now. Anyway, yeah, so Toradol is a really good option here, right? And again, would acetaminophen be a good option in this case? Not really, because it's not really working on that inflammation that's occurring there, right? You could give some, but it's not going to really be the biggest thing to benefit the patient. Toradol's a good one. Ibuprofen's fine. Naproxen's fine. If you had a person with high-risk GI history, it's a good one. So, oh yeah, I got a history of GI ulcers. Celebrex, right? Celecox was a good COX-2 selective agent. A lot of patients end up getting put on Celebrex, especially if they have really recurrent gouty attacks and you're worried about the GI history. That's what, I think about COX-2 selective agents there, right? And if it works, then you're going to be focusing on things like, modifying their diets. That way they're not developing this hyperuricemia, looking at things like urate lowering therapy. We'll talk about those briefly in just a little bit. For more severe pain, this is where you want to use combination therapy. So either like colchicine plus an NSAID, corticosteroids plus an NSAID, whatever the case may be. And again, if there's a very few number of joints, you could potentially use those intra-articular corticosteroids. That can be very, very useful in some cases there. And again, looking to see how they respond to it. If you can switch over to monotherapy, that's always going to be beneficial. Fewer drugs are typically better, as we know. And then from there, they will focus on the preventative therapies. We'll look at those in a minute. So, as I mentioned, to look at non-pharmacologic ways to try to prevent a recurrent attacks, one thing you can do is to try to maintain lower uric acid levels. So that can be done with things like diet, by trying to decrease the amount of, say, purines that are going to be ingested into the diet. That can be beneficial. Limiting alcohol intake. Why do you think that makes a difference? Yeah, because again, alcohol itself is a diuretic essentially, right? Because again, it helps to suppress what? Antidiuretic hormone, absolutely, right? So that's why people get really dehydrated after drinking, and so that can then cause sort of that contraction sort of effect where you would find the uric acid levels get more concentrated. And you can see an attack there, right? You want to avoid certain medications that can actually increase uric acid levels. A lot of this has to do with preventing it from being excreted through the kidneys, and so things like thiazide or loop diuretics can be a common cause of this. Not only that, but they also cause some dehydration and will cause it to concentrate. Niacin, where do we see niacin last? Yeah, we use it for hyperlipidemia, right? It's really good for getting down triglycerides, increasing your HDLs. Again, that's something you can find over the counter potentially, right? So you have to make sure you're letting patients know to maybe avoid that if they have a history of gout. Because again, think about these older guys who have bad diets and they're taking stuff for their lipids, and they say, hey, you should take some niacin. And they have these gouty attacks. That could be something you need to look at as being a possible causative agent. And even low-dose aspirin can have some effects to increase uric acid levels. Okay, so just be aware of these different things. If you can try to get them off of it, that's good. If not, then you need to look at some other ways to deal with that uric acid level. Okay. So how we can do that, we have our urate lowering therapy, and so these tend to be pretty effective for patients who have maybe 2 or more attacks a year, right? If it's only like once a year they're having this, they may not need to go on kind of chronic therapy. Maybe they just have a as needed prescription for, say, Celebrex, just to take if they have an acute gouty attack, something like that. And then also, if they have a history of, say, urolithiasis, they have a history of chronic kidney disease, these may be good patients to also go on urate lowering therapy to help them prevent from holding on to that for long term, right? And so we'll find that we can either work on decreasing the synthesis, I can't even talk anymore, decrease the synthesis of uric acid. This is where our xanthine oxidase inhibitors are going to come into play. I can say really hard drug names, but I can't say synthesis very well. Anyway, or we can increase the uric acid excretion. We call these uricosurics. It's going to cause us to basically pee out more of the uric acid than we would otherwise. Okay. So this is the pathway I wanted you to memorize, if possible. Just kidding, don't do that. Right? It's very complicated. I'm sorry if you ever had to memorize this in previous times. The thing I want you to know is that while it is a complicated pathway, we're really just considering the very last 2 steps here, right? Basically, these last 2 steps are what actually produces the uric acid. It goes from hypoxanthine to xanthine to uric acid. So if we can inhibit that process, doesn't matter what's happening up here, ultimately we're going to be able to stop uric acid from being produced in the first place. These other products can be more water soluble, they can be eliminated, they don't have that same risk for precipitating out as uric acid monosodium crystals, so you don't have to worry about the gouty attacks from that. So xanthine oxidase is the enzyme that's responsible for these 2 steps. So if we can inhibit that, we can inhibit ultimately the formation of uric acid and drop those levels down. Okay. So xanthine oxidase inhibitors, as I mentioned, they're going to inhibit that enzyme there, so they will prevent that conversion from hypoxanthine to xanthine to uric acid. And the most widely known one that we have is going to be allopurinol. Xyloprim is the brand name there. And these are the most widely used agents in order to prevent recurrent gouty attacks. So if you have someone who's had a couple of different attacks in their past, these are good agents for them to be on. Allopurinol itself is pretty safe for the most part. You may see some leukopenia, maybe some GI upset, but it's very safe for the most part. You do want to be aware of any kind of skin manifestations that develop. They develop new rash, any kind of blisters, whether it be on the skin or in the oral epithelium, anything like that. That could be a sign that something like toxic epidermal necrolysis is developing. They need to know to stop taking it and they need to get checked out immediately, right? Another newer one that we have now is called flubuxostat, or Uric is the brand name there. Again, pretty well tolerated, probably a little bit better than the allopurinol, but it's more expensive because it is a newer product. I'm actually not sure if that's generic yet, but it would be more expensive than the allopurinol. Allopurinol has been around for basically forever. But yeah, some arthralgia, maybe transaminitis, but other than that, you know, no big issues with that drug. On the uricosuric side, this is going to help us to increase renal clearance. This is used far less commonly than what you would see than the uric, the xanthine oxidase inhibitors. Again, those are going to be most commonly used for prevention of gouty attacks. These may be used occasionally, but not as often. And so the one agent we have here is basically working to prevent the reabsorption of uric acid in the renal tubules. So it'll get filtered out through the glomerulus, but you're preventing it from getting reabsorbed back into the bloodstream, so you just pee it right out, right? This is why I call it a uricosuric, because you're just peeing out the uric acid. And probenecid is a big one. Now, again, you're increasing the levels of uric acid in the renal tubules, so what do you think could be a risk? Nephrolithiasis, right? So again, we're increasing concentrations in the renal tubules, increasing that risk for precipitating out and causing acute interstitial kidney injury, right? So again, that is a risk with this. About 10% of patients are going to experience that, which is why, again, we don't use it as commonly as we would use, say, something like allopurinol. Actually, what we used to use back in the day, so back when we first had developed penicillin, so they probably went to some college students like Fridge and said, look at this stuff growing here. We have penicillin, right? And so essentially what they said was, okay, well, we have this really new drug. It's revolutionizing medicine, but it's really expensive to make. We have a hard time getting it. How do we keep it around for longer? And so actually what they were doing is they were using probenecid to prevent the kidneys from excreting penicillins and cephalosporins out into the renal tubule, so your levels will stay higher for longer, and that way you give fewer doses, be a much more economical way to manage a lot of these infections back in the day. We don't have to do that anymore. So again, it's usually why you see don't see probenecid being used too often, but just know that it can inhibit secretion of other drugs in the renal tubule, so you may see levels increase, right? So again, something like a penicillin or cephalosporin could lead to some toxicity if the levels are too high due to that combination there. So just be aware of that, and we do not want to use it with patients with renal impairment, because again, that can just lead to more nephrolithiasis. One unique drug, this is actually one you will use exceedingly rarely. If you work in oncology, though, you may see it used occasionally. You want to know when to use it. It's called rasburicase or Elitec. And this is actually a recombinant form of an enzyme called urate oxidase. So what do you think it does? It oxidizes urate, right? So basically it takes uric acid and cleaves it into a much more water-soluble form and get rid of it immediately, right? So instead of working on preventing the formation of uric acid, this actually breaks down the uric acid that's already been made, right? Very, very potent drug, and we don't use it very often because it's a recombinant enzyme we're giving essentially, so it's extremely expensive. I'm thinking like in somewhere like in the $100,000 sort of range as far as this drug goes. And so whenever you decide to use it, like you really got to make sure you're hitting all the criteria. A lot of places will have like, say, you know, here's the criteria you have to hit in order to make sure you can use it, and then you have to call your boss, and you have to call your boss's boss to make sure you get clearance to use it, and then they call the director of pediatrics, and then everyone has to get their say in it on to actually use it. But where we use it is going to be in patients who develop tumor lysis syndrome after they receive chemotherapy. So, for instance, one case is like Burkitt's lymphoma. When you end up treating that, immediately you're lysing all of those white blood cells open. They're producing a ton of uric acid. And again, you're worried about the kidneys. You're worried about some other toxicities from that. So you have to give the rasburicase to try to cleave all of that, and they can pee it out, and they should be good to go. So just know, be careful with that. And some patients, hopefully, you don't have to give it more than once. They can develop things like antibodies against it, so you can actually have an anaphylactic reaction there. And then you also want to be careful with patients with a G6PD deficiency. Again, what happens when you have a G6PD deficiency and you receive an oxidizer? What color do you turn? You turn blue, because you have methemoglobinemia. It can lead to that and then also to eventual hemolysis. Okay, you guys talked about methemoglobinemia very much. You had to treat it. You have a blue patient, what do you give them? Give them methylene blue. You actually give them a blue dye and it turns them pink again. Go figure. Anyway, we can talk about that later, at a later date. But so looking at your different options here. So again, first line, you're always going to go with the uric acid lowering drug. And again, most often that's going to be antioxidase inhibitors. So allopurinol is typically going to be your first line agent there. Febuxostat is an alternative. And then if they don't have any renal dysfunction, maybe probenecid, but again, exceedingly rare, they're actually going to use that. Obviously, focus on the non-pharm stuff as well, with things like dietary modifications, things like that. And then try to eliminate any medications that could be exacerbating this. So if you can get them off of thiazide, get them off of a loop or something, that's always going to be beneficial from that standpoint. And again, you also want to have them have prescriptions for as needed anti-inflammatories if they do develop an attack, right? So that way they can go and they can fill their colchicine or Celebrex or whatever, what have you, and use that if they do have an attack occur. But they will be taking something like the allopurinol chronically, right? They're taking that every single day potentially. Anyway, so then based off of that, you're looking at your uric acid levels. You're going to be targeting those. Still not working, try to either maybe use multiple agents. Most of the time, though, you can get away with just the allopurinol, and then you kind of go from there. Okay, it's pretty straightforward. Just remember what's used for more acute gouty attacks, and what are things that are used for more of the chronic management of those uric acid levels, and how those drugs are working. Okay. Any questions on that? Nothing at all. All right, let's do a 10-minute break. We'll come back and we'll get in to OB-GYN.